Hi, this is Larry Benz, and this afternoon we're going to have the topic of Bo knows Bo. I've gone around and I've talked to a lot of physical therapy groups. I've been taking a little informal study. 3 questions. First question is, how many of you find physical therapy to be a rewarding and challenging career? As you might guess, nearly 100% raised their hand. Question number 2, how many of you today would like to learn verbal and manipulative techniques that produce nonspecific effects in your patients? Nobody's hands go up. Question number 3, how would you like to learn to better enhance and influence evidence-based outcomes in a positive way for your patients? Once again, all the hands go up. What you find, though, is question number 2 and 3 are exactly the same. Question number 2 is an example of negative loss framing. Question 3 is positive framing, and the first question was simply a distractor. In today's presentation, you'll learn how those same techniques can influence outcomes in an evidence-based way for your patients. A famed researcher was starting to get calls at night from his patients. He was conducting a randomized clinical trial of patients who were having very severe arm pain, carpal tunnel syndrome, chronic shoulder pain, wrist pain, and nearly a third of his 270 subjects were complaining of terrible side effects. You see, in one part of the study, half the subjects received pain-reducing pills. The other were offered acupuncture treatments. In both cases, people began to call in saying they couldn't get out of bed. The pills were making them sluggish. The needles caused swelling and redness, and some patients' pain ballooned to nightmarish levels. You see, the symptoms were exactly what the patients had been warned their treatment might produce. But even more astounding, most of the other patients reported real relief. And those who received the acupuncture felt even better than those on the anti-pain pill. These were exceptional findings. You see, nobody had ever proven that acupuncture worked better than painkillers. This study didn't prove it either. You see, the pills his team had given the patients were actually made of cornstarch. The acupuncture needles were retractable shams that never pierced the skin. See, the study wasn't aimed at comparing 2 treatments. It was designed to compare 2 fakes. Second experiment. This one had 262 adults with IBS, and they were put into 3 groups. A no-treatment control group, told they were waiting on a waiting list for treatment, a second group who received sham acupuncture without much interaction with the practitioner, and the third group who received sham acupuncture with great lavished attention upon them. At least 20 minutes of very what you'd call schmaltzy care. I'm so glad to meet you. I know how difficult this is for you. This treatment has excellent results. Practitioners were required to touch the hands or shoulders of members of this third group and spend at least 20 seconds lost in thoughtful silence. The results were not that surprising. The patients who experienced the greatest relief were those who received the most care. Dose-dependent response for placebo. The more care people got, even if it was fake care, the better they tended to fare. Third study. 180 patients with osteoarthritis of the knee were randomly assigned to receive debridement, arthroscopic lavage, or placebo surgery. You see, patients in the placebo group received skin incision and underwent a simulated debridement without insertion of the arthroscope. The outcomes were no difference across groups, with objective function better in the placebo group at some points in time. I've labeled this presentation, Bo knows Bo. Not just because it's about placebo and nocebo, but to give credence and honor to one of my favorite athletes and one of my favorite all-time commercials, Bo Jackson, the athlete of all sports. To signify for us as physical therapists, we need to be athletes of all evidence to integrate with our patients. Let's define placebo and nocebo effect. Placebo is the phenomena in which a patient's symptoms may improve while receiving an inactive substance in a clinical trial. You see, it's been research that has produced the phenomenon we call placebo and nocebo. Without clinical research, we wouldn't know that the phenomenon exists. Nocebo, on the other hand, is a negative counterpart to that. It refers to adverse or harmful effects experienced by those receiving an inactive placebo. But I want you to think of these things in a new and different way and embrace placebo and try to negate nocebo and try to influence outcomes. Think of these effects as either specific or non-specific. Specific effects are what your intervention is intended to do based on your judgment, your experience, and the evidence for it. It is caused by the elements of that intervention. It is what you intended to do. Nocebo and placebo, though, will fall into non-specifics. It's a placebo if the effects are beneficial, and it's a nocebo if the effects are harmful. Let me give you an example. In one of the most famed placebo studies of all time, they told a group of participants that they were going to take one of 3 pills, and they randomly assigned them a stimulant, a relaxant, and a placebo. What the students didn't know, or the participants didn't realize, was there was a magnet in these inert capsules, and in fact, they were a sham. There was nothing active. They put a magnet in simply to trace the speed that they went through the GI tract. They were astounded to find the results that those pills that were perceived as a stimulant beat the relaxant, which in turn beat the placebo. Now, the one thing we can say is that a placebo, because it's inactive, cannot cause a placebo effect. There's something else has to be going on. And yes, techniques can be considered manipulative. If you look at the Edwards study titled The Effects of Framing and Other Manipulations on Patient Outcomes. Let me give you another example. They recruited a group of students and informed them that they would be subject to a procedure. They were going to get administration of electric current to their heads that could induce headaches. Even though no electricity was administered, the majority of participants received headaches, a manipulative technique. Now we're going to walk through everything you wanted to know about placebo and nocebo, but were afraid to ask. We're going to talk about whether it's a physiologic or a mental phenomenon, ways to enhance placebo, ways to negate nocebo, who is susceptible by diagnosis, gender, and nationality, and what are the key take-home points. The first topic, physical or mental. There is a gross misperception about placebo. Even medical practitioners think placebo is a mental phenomenon or a psychiatric phenomenon. The reality is that there's been a ton of research that clearly demonstrate a physical response. If you take naloxone and block literally the body's ability to produce an endorphin or its natural pain-relieving abilities, you will in effect ruin the placebo effect. This has been demonstrated in multiple studies. The advent of functional magnetic imaging demonstrates activity within the cortices of the brainstem and the spinal cord during a placebo analgesic response. We could go on, but trust me, the research supports that placebo is physical. Certainly there's a mental component to it, but it is not a mental-only response. Ways to enhance the placebo. The 3 key messages today are enhance the placebo, negate the nocebo, influence outcomes. Let's look at enhancement. The key thing about enhancement is to realize the impact of your words in communication. Lone's quotes here demonstrate that a doctor possesses words like a two-edged sword, which can maim as well as heal. And communication to patients does, in fact, that. First way of enhancing is positivity. The way that you're able to communicate with patients in a positive way influences outcomes. just like the second example I gave you of the schmaltzy care. More care, more positive care led to better outcomes. There have been over 25 RCTs that found that enhancing patterns result from positivity. Barbara Fredrickson's work out of North Carolina shows a ratio of 3-to-1 positives to negatives results in patients and folks that will flourish. When we provide that support of reassurance, we support and influence health outcomes in a positive way. Look at this study of 200 patients. These were patients that had symptoms, but no abnormal findings. Ever have any of those? And they also had no diagnosis that could be made. Ever have any of those patients? They put them in a randomly assigned to a treatment or a no treatment group. The positive consultation group consisted of a firm diagnosis, and the patient was told confidently that this is your diagnosis and you're going to be better in a few days. The negative consultation group was told that they weren't quite sure what the diagnosis, we don't know what you have, and we're not sure how long it's going to take before you get better. The results? Even though there was no treatment difference in how they were ultimately treated between the two groups, the positive group produced significantly faster results. This study, ironically, was replicated in an odd group, those with acute tonsillitis, and they had the same results. All things being equal, the positive therapist wins every time. Egbert refers to this type of positivity as the placebo response without the placebo, because they weren't given an inert or sham treatment or pill. Second way to enhance is through positive framing, which is what I did in my third opening question. In positive framing, you focus on tolerability. So for example, you would say to a patient, the great majority of patients who have what you have tolerate this treatment very well and they do great. That is positive framing. Negative framing would be something to the effect of 5% of our patients report. When you say that, patients key in on that 5% and they consider themselves part of the 5%. When they've looked at elective surgery, even in life and death threatening situations, if given the choice, patients will self-select into a physician who says you have a 90% chance for survival versus a physician that says you have 10% chance of dying. Frame in a very positive, in a very way that gives a gain to the patient for their benefit. Further studies have been done on flu vaccinations, showing that when you tell somebody who's taken a flu vaccination that the majority of people do great, they're back to work right now, they have no ill effects from this virus, versus a small group that you tell them that this might cause a headache, you may have to miss a day of work, you may get a fever. The results overwhelmingly demonstrate that that second group inherits those adverse effects. Positive framing. An additional way that you could profoundly impact the placebo and enhance outcomes is through shaping expectations. In fact, there's more support in the literature for this than any other technique. A systematic review of over 85 studies show that the mechanism for placebo effect is shaping expectation. In fact, this is more important in physical therapy than perhaps any other area of medicine. Rausch has demonstrated in his studies that patients attending physical therapy don't know what to expect. Many have never been to physical therapy, and they automatically associate it as though it were a physician visit. The most important question you can ask a patient is, what is your expectation? The second most important thing you can do is define what will happen through their interaction in physical therapy. In fact, Chen's work has demonstrated that really shaping expectation is a mediator of outcome, that the dependent variable so much is influenced through a mediation of expectation that an outcome has a preponderant way of occurring should you shape those expectations. The next way to enhance is through patient preferences. We had positivity, shaping expectations, and now patient preferences. In fact, interestingly enough, patient preference has been shown in some research cycles as being equivalent to placebo being equivalent to patient outcome. If a patient comes to you with such a strong preference for a certain technique, unless it's harmful, you'd be hard-pressed not to do it. The research supports preferences in exercise and diet programs, and it influences outcomes. How do you enhance taking these three factors into account? Well, the general concept is known as meaning in medicine, or the power of routine. You see, a group of medical students was asked to participate in a study of two new drugs, one a tranquilizer and the other a stimulant. Each student was given a packet containing either one or two blue or red tablets. You see, the tablets were inert. The students' responses to a questionnaire indicated that the red tablets acted as a stimulant, while the blue ones acted as a depressant. And two tablets were more effective than one. This can only be explained by the meanings in the experiment. See, red means up, hot, danger, while blue means down, cool, and quiet. And of course, we all know that two pills mean more than one. The effects of color and number of pills have been widely replicated. A second study involving the meaning effect is one of my favorites that come out of the UK. 835 women who regularly used analgesics for headaches were randomly assigned to one of four groups. One group received aspirin labeled with the most widely advertised brand names in the UK, and it had been supported through extensive advertising. The other groups received the same aspirin in a plain package, a placebo marked with the same widely advertised brand name, and the fourth group an unmarked placebo. You see, in this study, branded aspirin worked better than unbranded aspirin, which worked better than branded placebo, which worked better than unbranded placebo, but among the 435 headaches reported by the branded placebo users, 64% were reported as improved 1 hour after taking that pill. You see, taking a dose of aspirin works, and it works to relieve headaches if you believe that you are taking a good aspirin. The third meaning response is meaning in exercise. In a study of aerobic exercise involving participants in a 10-week program, one group was told that the exercise would enhance their aerobic capacity. A second group was told that the exercise would enhance their aerobic capacity as well as their psychological well-being. Both groups improved their aerobic capacity, but only the second group improved in psychological well-being. You see, the researchers called this strong evidence that exercise may enhance psychological well-being via a placebo effect, a strong one at that. You see, I'm convinced that this ritual takes place in physical therapy as well. We have certain uniforms we wear. Our waiting rooms look predictable. I'm convinced that we can use this ritual routine to enhance outcomes in a positive way in physical therapy. We have predictable uniforms that we work in. And you see, even items like acupuncture and dry needling are very susceptible to the placebo effect. There's even been studies that have compared placebo of sham acupuncture to real acupuncture to an analgesic. And in almost every one of those cases, the sham acupuncture performs as equal to real acupuncture, which almost always is either equivalent or better than a pill. Routine in the ritual response of enhancing the placebo effect. The last area of meaning in response is the logical and clear description that the practitioner talks to the patient about. Let me give you an example from the research. If I'm a physician and I say to a patient, I will clean up a messy joint of yours through knee arthroscopy, how much different and better is that than if I say to the patient, we're going to prescribe an anti-inflammatory that will inhibit the production of prostaglandins, which is involved in the inflammatory process. Or even worse, if they send you to physical therapy because of all the magic bells and whistles that will work. You see, surgery has a significant meaning response. And a significant component of surgery is, in fact, the placebo effect. But it's the clarity of the language cleaning up a messy knee that makes sense to patients. And that's what we have to keep in mind. Now, a last way to enhance the placebo effect is in many ways the most interesting. It is something we can do every day, and that's simply monitoring adherence. Adherence to the medicine and adherence to exercise. If the medicine is a home program, so be it. When they measure adherence in terms of medication, it's usually whether or not they take a pill 80% of the time. You see, in cardiac research, for example, those studies are conducted over many years. And in one study of beta blockers, the adherers, which were 80% adhering to a drug for over 5 years, had a mortality rate that was equivalent to a placebo of adherers, 80% over 5 years. You see, simply taking medicine sends a signal to the body that we're doing something good, and it has a strong and powerful effect. Even in the alternative medicine research of placebo, they find one of the key facilitators is the commitment or the level of responsibility that the patient is involved in the process, whether that be paying their copay, adopting the lifestyle, participating in the exercise program, and the like. Adherence is critical to a positive outcome in influencing the placebo effect. A related manner would be patient satisfaction. You see, the patient satisfaction research has shown time and time again that a positive interpersonal relationship and a high-quality connection with the practitioner leads to better compliance of the patient and the regimen that they were given instructions in. Negate. How do we negate the nocebo effect? There are a number of means. The first is language again. Using verbiage like reactions are benign and mean the medicine is in their system. When patients have soreness, when they have consequences of physical therapy interventions, don't respond about their pain and their soreness. Respond that that's a good thing because it shows that they were following proper instructions and the treatment is working in their body. There are other ways to negate. Never mention certain words, particularly pain. In fact, there are other words that do the same thing. There are just times when you can't be too sympathetic. A study of patients receiving injections of radiographic substances showed that their anxiety and pain were heightened by the use of negative words, such as sting, burn, hurt, bad, and pain when explaining the procedure or expressing sympathy. In another study, injection of local anesthetic before the induction of epidural anesthesia in women about to give birth was announced. Either we're going to give you a local anesthetic that will numb the area so that you will be comfortable during the procedure, or you're going to feel a big bee sting. This is the worst part of the procedure. The perceived pain was significantly greater in the latter statement. Information about the occurrence of pain, interestingly enough, increases even if only once. In other words, you create this heightened sensitivity when you use the words burn, sting, pain that has been tracked in the activity of the insular cortex as long as 8 and even up to 90 days. If you ever use those words to pain, in other words, burning, it's going to hurt, this is the worst of the procedure, it stays with the patient for a long time after that procedure itself. There are just simply times where you can't be sympathetic. Another way to negate nocebo is my favorite way, which is authorized concealment. This is a phenomenon that's actually legal in many countries, and for certain procedures in the U.S., it is legal. And that's the idea that you agree to receive or not receive information about certain types of side effects. It would look like this. Based on research, we know that patients who are told about these sorts of effects are more likely to experience them than those who are not told. Now, do you want me to inform you about these side effects or not? What they find is this concealment will negate the nocebo 90% of the time. If you want to really impact nocebo, effectively use medical jargon. In study after study, when they use medical jargon on the sides of pills bottles of pills, and that jargon is not understandable by a patient, guess what? They don't have the side effect. But if you use terms like nausea, vomiting, fatigue, headaches, you greatly influence those adverse effects. Those are enhancement, those are negate. Now let's talk about patients that are the most susceptible to placebo. There has been a ton of work, and not surprising, and this is good news for physical therapists, that back and chronic pain as well as arthritis, those patients have a high susceptibility to the influence of placebo and its counterpart, nocebo. Is this susceptibility genetic? Well, as it turns out, they've been able to identify a gene that tells the practitioner or the researcher whether or not there's a susceptibility to placebo. And think how much beneficial this is to the drug companies performing clinical research. You could eliminate those who are susceptible to placebo, at least theoretically, and then you'd get true results of what the medicine is intended to do. Most notably, the predisposition is in those areas where genetics has had an ability to impart, which is in depression and social anxiety. Those are a genetic susceptibility. Is there a gender difference? As it turns out, there's no real difference between men and women relative to their ability to be influenced by placebo and nocebo, but they're influenced differently. For women, it's through conditioning. Think stimulus effect. Think Pavlov's dogs. In studies after study of chemotherapy, if they take a lemon juice drink with the chemo, they begin to associate that and begin to have nausea and vomiting with just the sight and the smell of the lemon juice. You can use this in a positive way, though. If you've had a positive effect from a visit to a physical therapist, you're more likely to associate that in a conditioning way for future visits. With men, though, they're even the most susceptible to shaping of expectations. See, men like to be told what to do and what to expect. Look at a very large study on BPH. Men who were given drugs were put into two groups. One group was told they'd have various sexual dysfunctions. A second group wasn't told anything. As you can imagine, the group that was told they'd have dysfunction had it 3-1 over the group that didn't. Gender differences. The last difference is also extremely interesting, is nationality differences. In Brazil, the placebo effect is about 7% or almost non-existent. Interesting, though, in Germany, the effect is 59% placebo in Germans, which is about twice as high as the rest of the world. And what's interesting, in nearby northern countries there, 3 times those countries of Denmark and the Netherlands, where in 5 studies their average placebo effect was about 22%. Lots of differences in people. Enhance, negate, influence. You need to embrace the placebo and non-specific effects by shaping expectations, being positive, framing in a positive way, monitoring adherence, and understanding how to negate the nocebo. With all of this wonderful information about enhancing the placebo and negating the nocebo, I'm reminded by this Sanderson quote, which essentially says, we are still constrained to use treatments for which we know there is good evidence, and most particularly to avoid those which cause harm. Said differently, we use placebo to enhance but not to replace evidence-based direct interventions. For a song to remember nocebo and placebo, at my Manipalooza presentation, I went off my Springsteen set and decided on an oldie but goodie. It's Peter Frampton's Show Me the Way. And that is a symbol for us to remember as physical therapists that our patients are asking us to help them shape the expectations, positivity, and influence the outcomes. But they need us to show them the way.